Well, Dr. Bestermann, you spent many years in Beaufort practicing internal medicine.
Right.
What kind of experiences really stayed with you through that?
Yes, well, when I first went there, it was a little hospital, 60 beds from World War II, no ICU. And so I was the first full-time internist there, and half the people were dying of heart attacks and strokes. So I became medical director as we started the ICU, and for 8 years, it was my job to come out of the ICU, face people I knew in that small town, and give them this terrible news. Your dad's not going to make it. Your mother's had a stroke. She's not going to be able to talk. She's paralyzed on one side. Your brother's going to have dialysis. And these were very emotionally charged issues. So I became very driven by it. I became president of the American Heart Association chapter in South Carolina, and then worked with a cardiovascular center of excellence program. Now, the Institute of Medicine, back in 2001, came out with a document, Crossing the Quality Chasm, and they talked about the 17-year gap between what we know and what we do in cardiovascular disease. Well, in chronic diseases in general, and in no part of American medicine is the gap greater than in cardiovascular disease. So the real shining light on that goes back to 1988. And the first two studies were done that showed that heart attacks, only 14% of heart attacks occur where the blockage prior to the heart attack would have been as much as 70% in that artery. And that's the level required for a stent. And so you're not going to prevent or stop most heart attacks with stents and bypasses and other procedures. It is optimal medical therapy that is the best treatment for heart attacks and strokes, and that's what primary care does.
Okay. So that seems very different than what is being seen as general practices today, isn't that?
Absolutely. So there's this huge gap between what we know and what we do. The Institute of Medicine talked about 17 years. In cardiology, it's 27 or 28 years. And there are lots of reasons for that. I think one of the big reasons is fee-for-service medicine, and there's big money in doing these very sophisticated procedures and not very much money in producing optimal medical therapy, which science documents is the best treatment. So I've been very interested in this best practices space now for 15 plus years, and was actually working some in that space, working with the Medical University of South Carolina a couple of years even before that Institute of Medicine program came out. And then 7 years ago, I went to a big practice in Kingsport, Tennessee, where we formed a focused, advanced medical home team within a much bigger practice to address the needs of these high-risk patients. And that's when Dr. Carmouche, the CMO at Blue Cross and Blue Shield of Louisiana, and I began to learn about each other at cardiovascular center of excellence meetings.
Okay.
The work that I did in Kingsport was in a big practice, so 50,000 patient visits a month, lots of patients. And what we did within that practice was we would pull in patients from the broader practice who are not well controlled or who are at particularly high risk, and work very hard to see that they got optimal medical therapy.
What is significant or different about what's happening at Blue Cross Blue Shield in this area of cardiovascular treatment?
Okay, so I was doing this work in Kingsport, Tennessee. A number of us were meeting at these Center of Excellence meetings from across the Southeast. Dr. David Carmouche was doing that same work in the Baton Rouge Clinic in Louisiana. Blue Cross of Louisiana heard about his work and began talking with him, and long story short, he became the chief medical officer there. And he entered that organization about 2.5 years ago and started this kind of work to bring what I'm talking about to a state health plan. And about a year into that, he had it going well enough that he brought me in to work with him as a consultant to bring these kinds of best practices to bear.
Can you give me an example of some of the treatments or best practices that are being put into play?
Yeah, so when we talked about this, we were trying to figure out how would you explain this in simple terms that medical people who weren't focused in this area could understand or laymen could understand. And basically, a lot of people have pieces and parts of this, but you're not going to really get this done unless you have a comprehensive solution. Okay, and it's very difficult. We struggled a lot in Kingsport because we were in a fee-for-service environment, and we were not getting extra pay generally for doing this work. You can't see 30 patients a day doing this. You can only see 20, so we weren't the most productive people in the practice. You have to have the payer involved. You've got to have a new payment model along with the new science and the new systems. So what it takes to improve is what Dr. Carmouche was working to comprehensively implement in Louisiana. And so he identified 4 different conditions that we would pay doctors extra money for managing well. So it was diabetes, hypertension, chronic kidney disease, and coronary artery disease. And if you were in the best performing group, you got as much as $25 per member per month. If you were in that middle group, you got extra money, but not as much. Ultimately, in a couple of years, if you're in the bottom tier, you will be penalized. Okay. And so there's a comprehensive solution involves data management. So they've brought in a data company, Symphony Health, MD Data Core, and they have connected the electronic medical record in each of these doctors' practices back to Blue Cross Blue Shield. And what that enables Blue Cross Blue Shield to do is see what is the blood pressure level, what is the cholesterol level, what is the diabetes control level, how are the weights changing. And we can only see Blue Cross Blue Shield data, but the doctor can use this tool that Blue Cross and Blue Shield has provided to see all of their patients. And so they can, using that tool, they can identify all of the people who are not well managed. We also coach them in best practice clinical protocols. And an example I can give you, and these are very simple, okay? It's not real complicated. But Dr. Carmouche and I, for some time before, had worked on what would the best practices be for hypertension and high cholesterol and diabetes. And for hypertension, my LPN could tell me what I did for hypertension. We started with an ACE inhibitor like lisinopril. The second drug would be a diuretic like a thiazide. The third drug would be amlodipine. And if they were still not well controlled, the fourth drug was an aldosterone antagonist like spironolactone. So the beauty of that is you can have a team. I had a team. I was the supervising physician. I had 3 PharmDs who the particular insurance we were involved with would pay them just like they were a doctor. So they operated off of these evidence-based protocols, and that enables you to get many more patients this best practice care at lower cost.
Now, Dr. Bestermann, how can what is being done through Blue Cross Blue Shield Louisiana be seen as a standard for what other organizations can take up as a strategy that works?
Well, I think you can see over here that we did produce a 12% improvement over the entire state in just a year in the number of people who achieved all of their diabetes care goals. Control of their A1C, control of their LDL cholesterol, and control of their blood pressure. Some of these things improved substantially. The improvement in blood pressure was 28%, and that's across the state.
Yeah.
So lots of heavy lifting. We've just begun. We've learned as much about what didn't work as what did, but we've begun the journey, and we've modeled it around very commonly known clinical trials and best practices, and what the Institute of Medicine specifically recommended to improve the treatment of chronic conditions.
Okay. Dr. Bestermann, we're going to have to leave it there, but I did want to ask you, what do you think is most significant that I haven't asked you that you'd like to add?
Why it's been so hard.
Okay.
We've been at this 15 years. The Institute of Medicine report came out in 2001. They made very specific recommendations for improvement, and here we are. This effort should be what's going on in our whole system, but it's very unusual, and I have to put it down to lack of understanding and perverse financial incentives, frankly.
Okay. Dr. Bestermann, thank you so much for your time today.